Hello, everybody. I'd like to spend some time today talking about the hygiene exam in the dental office, specifically the CDT code D0120. There's a couple different goals I'm going to try to provide here today. So the goals for this discussion is one, to provide clarity for both the doctors and the hygienists with the expectations for the periodic exam in the dental office. Also, to provide an efficient workflow so that one, the patients get the attention that they need. Maybe most importantly, so that hygienists don't feel like their time with their patients is hijacked by lengthy doctor exams. And also, so that time is not taken away from the doctor's chair, so that they can be efficient doing what they do, whether it's surgical or restorative. Also, one of the goals today is to provide an ethical framework so that everybody feels good about what's being done and not done during the hygiene exam. Dovetailing to this, maintenance of standards according to our governing bodies, such as the State Dental Board and the ADA Code of Ethics. So what is the CDT code definition for D0120, the periodic examination? So CDT is an acronym for the coding on dental terminology. The goal of this through the ADA is to provide uniformity in the codes and procedures that we do so that insurance companies can assure that there's alignment with the procedures being done. But even outside of the world of insurances, it provides, again, uniformity and alignment with the procedures that we do. So specifically in the CDT code terminology, which is updated yearly, the D0120 dental code is an examination that is performed on a previously assessed patient. So this patient either already had a D0150, a D150, or D180 code. So a previously assessed patient to determine changes. So again, we're not creating information acquisition for a new patient, but we're determining if there's changes in the dental health since the last assessment. That's an important point here. It includes oral cancer screening or an oral cancer evaluation, a periodontal screening, and information interpretation amongst a list of several assessments. And we'll go over all this momentarily. Again, this is on a previously assessed patient. The reason I underline this here, young doctors sometimes fall into the routine of feeling like they need to do a thorough examination, go over every single millimeter of every tooth in the mouth. That's not it. That patient already had that evaluation done during their new patient exam, which is a more lengthy and more in-depth examination. This is an assessment of a previously assessed patient. Also in this description, there was a mention of oral cancer screening or an oral cancer evaluation. For today's conversation, we'll consider those one and the same. A periodontal screening, we'll go over what that is. And then also information interpretation among a list of several assessments. Radiographic assessment, caries risk management assessment, airway assessment, all of those things can be part of this periodic examination. So this comes from Charles Blair. Charles Blair is a dentist who created a very helpful book called Coding with Confidence. He now has several other books which are updated yearly. Coding with Confidence is the industry it's one of the most important documents when it comes to understanding what the CDT codes are. You'd think that the CDT world would provide clear explanations, but they stay away from that. They provide very high-level descriptions, and then a lot of the interpretation of those descriptions is dependent upon a variety of factors, standards of care, your state board, expectations, so on and so forth. So Dr. Blair does a good job of helping us interpret what a lot of this information is. So this came from his 2022 book, but this description is literally word for word from the American Dental Association, which I have already read. The part I didn't have here is the findings are discussed with the patient. And that's an important part here because sometimes doctors rely on their hygienist to have the findings discussed with the patient. I'll leave that up to each individual licensed doctor to determine what they feel is relevant or not. With that said, I think it's an important thing to build value in the eyes of the patient by having at least a high-level discussion on what's going on in their mouth from the doctor. We'll go over that more momentarily. So the next several slides are excerpts from Dr. Charles Blair, Coding with Confidence. This comes from the website, so it's the 2023 version. Again, all of this stuff is updated yearly, so there is a time-bound nature to this information. Important to keep in mind. So here, it's improper to report a periodic oral evaluation or any other evaluation unless the doctor completed the clinical evaluation on the patient and performed the evaluation. Now, evaluation here is somewhat ambiguous and amorphous of a term because it's not specifically saying that the doctor needs to go in and screen. So again, we're going to go over this in detail. The hygienist can screen, that's right here, a hygienist can screen but not diagnose unless specifically permitted by state law. In the state of Maine where we are located, there is no permitting right now of the hygienist being able to do that. With that said, there is quite a bit of activity going on at the state level to allow independent practicing hygienists to do more diagnosis. Topic for another day. So, again, the doctor needs to do the evaluation. That doesn't mean they have to go through and look at all the teeth. It just means they need to look at all of the information through the screening done by the hygienist and then having a conversation about the diagnosis with the patient. We're going to go over this in great detail. So again, the diagnosis is delivered by the doctor and the subsequent treatment plan proposal. So if you have a diagnosis, more often than not, you're going to have a treatment recommendation that follows. Each doctor can decide how they make sure that this is done, but at the end of the day, when a doctor does an examination, it's done under their license, not the practice's license. The practice doesn't have a license. So if you are the doctor doing a hygiene exam, you are responsible for the information held within that examination with the patient. So keep in mind that as a doctor, you need to make sure that information is delivered and understood by the patient, and also that the notes reflect that specifically. So here, this goes on talking about the oral cancer evaluation. This should be done by the doctor. The fact that the oral cancer evaluation was done and any significant findings should be documented in the clinical notes. So this brings up another point. The doctor should be countersigning the hygiene notes. Again, if a doctor goes in and does an exam, it's his or her license that is overseeing that particular hygienist's actions and lack thereof. So the doctors are taking that responsibility. It would be a good idea to countersign those notes at the end of the day to indicate that the information held within is appropriate for that doctor's standards. Again, this is not the responsibility of the practice. More on that later if you guys want to have the conversation. So as far as reimbursement frequency, this is starting to get a little bit down the road of insurances. It's not really the goal of today. But there are some important points here. The periodic oral evaluation is typically subject to 2 evaluations per year or once per 6 months limitation within the dental insurance contract. To control costs, some employers are choosing plans that now have the 1 evaluation per year limitation. So this is important to know, and this involves very good work with the front office team to make sure that we know ahead of time whether or not they have a plan that controls the frequency of these evaluations. With this is the concept of how often should we be doing this? That's really up to the doctor. Most practices try to do an examination every time. Obviously, there are procedures that the doctor is doing where he or she cannot be pulled away. I'll say the following. The goal is to do 2 evaluations per year, especially if the insurance is going to cover it. If the insurance is not covering or they're cash paying and they're low risk, the doctor may or may not choose to do once per year. Again, that's up to the doctor, but definitely no less than once per year. So in that description, there was a term here, periodontal screening. What is meant by periodontal screening? So here, I'm going to a specific excerpt from Charles Blair's book. The periodic oral evaluation includes periodontal screening where indicated. Where indicated, what does that mean? Well, basically what they're saying is you don't need to do it on everybody. It's not an expectation unless defined by your state dental board. But it's a good idea if the patient is at any elevated risk, it might be a good idea to do periodontal screenings with some sort of regularity. I'm going to go over this more. the screening may or may not be performed at that visit. So not every single visit requires periodontal screening. Again, we're going to define what periodontal screening means. This does not mean complete periodontal probing, and charting is required at each periodontal oral evaluation, that's the D120, in order to report the periodontal oral evaluation code. What does that mean? That means that we do not need to probe every single time that we do a D120. It is true when we do a D180, and we're going to go over that in a moment. But what's important to know here is that we do not need to do that every single time, but it should be done with some sort of frequency. And again, that's once per year. There is no separate standalone code for full mouth periodontal probing, meaning there's no code that says I'm doing a full mouth probing. There is under certain conditions, that's what the D180 is, but there's no specific code for every patient. It's inherent under the global fee of the D120 if and when it's done. All right. Where does the D180 come in? This is really a topic for perio maintenance patients, not the topic for today, but just to kind of tie these two together. The D180 code is a full mouth probing and charting performed on a separate standalone visit for a patient with high perio risk. Your smokers, your diabetics, your patients that have been diagnosed with periodontal disease in the past. And then lastly, some patients may not require a periodontal screening, such as young children and edentulous patients. So periodontal screening, what does it mean? PSR score, that's an acronym used to do almost like a quadrant assessment where you record the deepest pocket within each quadrant of the mouth. That's a tool used, but it's not necessarily something that we should be used to replace a full mouth probing. We're going to go over this in more detail. So screening via PSR, screening versus full mouth probing, or screening versus D180. So to gain some insight, I always like to go to Diane Glasgow Watterson's, I don't know if she has a website, but she posts a lot in, I don't know if it's Hygiene Today or RDH Mag. So there's a lot of postings by this hygienist who has her MBA and her hygiene license on all kinds of things relating to hygiene and standards of care within hygiene. She does some very, very good interpretations for us. So this website here is where I pulled all of these following excerpts. So the question that was asked and then what she answered was, what is the standard of care for new and existing patients with regard to periodontal screening and recording versus full comprehensive periodontal charting? So before I go on, the goal of today is not to spend so much time on this topic, but it dovetails nicely. The goal is to create an efficient workflow for the hygienist and the doctor so that they're all on the same page. But this is an important part of it. All right, so according to Frank DeLuca, DMD JD, JD indicating he's a lawyer and a dentist, so somebody who can oversee the entire profession from both a clinical and legal perspective. So he says, the standard of care in dentistry for periodontal charting is a full mouth 6-point probing with all numbers recorded at a minimum of once per year for all adult patients. The reason he recommends recording all numbers is that if a jury of non-dental individuals examines a periodontal chart that has only a few scattered numbers, quote unquote PSR, it appears to them as an incomplete chart. Remember, in the eyes of the laws, if it's not recorded in the chart, it never happened. So unfortunately, if we are ever to end up in the court of law, it's not necessarily our peers that are judging us, but a jury of non-dental individuals that receive information from a panel of experts on both sides of the law, or both sides of the lawsuit. Hopefully we never end up there, but how do we position ourselves to be successful in the event that happens? What he's saying here is once a year, 6-point probings, your standard periodontal charting should be done. She also goes on to say that if you ask 10 periodontists how often a patient should receive this more comprehensive 6-point periodontal charting, most if not all will say once per year. Now keep in mind, periodontists see periodontal patients, so of course they're going to say that. There's a lot of ambiguity in what should and shouldn't be done. I've worked for practices where the PSR score is the standard for patients of low risk. It's much more efficient. Can't say whether that's right or wrong, but for now, and until we can gain more clarity, once per year, the periodontal charting, 6-point periodontal charting should be done. Just another, I think it's important for us to go over this. So an expert witness who has served in 242 dental negligence cases writes, the fifth most common alleged negligence was failure to diagnose or treat periodontal disease in a timely fashion. There were 19 such cases, and all defendants were general dentists. In the majority of these cases, X-rays were not taken routinely, and periodontal probings were rarely or never recorded. So basically, we need to do this regularly. We're going to go over the frequency of this, essentially once per year, and radiographs once per year, to keep us within the guidelines set forth by the standards of care in our profession. Moving forward, this is Diane Glasgow-Waterson making her summary statement. My answer to you, the person who asked the question, is that I agree with your former employer, the periodontist. So this person who asked her the question had worked for a periodontist where things were done more thoroughly. Now she works for a general dentist where the PSR score is the standard evaluation. She then writes, PSR has utility only as a screening tool and was never meant to take place of a comprehensive periodontal charting and recording. So I'm not sure where the PSR plays a role. Topic for another day. From our perspective moving forward, it's the comprehensive periodontal charting that we're going to be doing. So what are the frequencies of probings and radiographs? Again, this dovetails with the D120 code. So once a year, we should be doing a full mouth probing. I'll leave it up to the doctors how they want to move forward with the following. Are we measuring recession, clinical attachment loss, bone level loss, mucogingival junction location, so on and so forth? Bleeding on probing, mobility fremitus. It's rather time consuming for a non-high risk or moderate risk patient. So we're going to gain some more clarity as time goes on. I think what the hygienists do now is good, is they do that when they see the patient would benefit from having that information tracked year over year. We're going to gain some more clarity on that as time goes forward. But at a minimum, measuring the pockets. And then once per year, necessary radiographs, the bite wings, the FMX, the pan, the vertical bite wings, so on and so forth. So in other words, we're alternating diagnostic modalities at each visit. So the patient visits the office twice per year. Again, this is a non-perio patient. At one visit, they'll have the full mouth probing, and at the next visit, they'll have the x-rays. That should take the hygienist about 10 minutes out of their recall and prophylaxis appointment. By doing them in an alternating fashion, it allows them to standardize their 1-hour appointment times. So again, D180 and its relationship to D120. So D120 is the periodic oral evaluation for non-perio patients. D180 is a beefed up version of 120 for perio patients. So here he goes on by saying the periodic oral evaluation includes a mandatory oral cancer evaluation by the dentist. We know this is not done in many practices, at least not with any sort of regularity. It needs to be done by the dentist. It would be considered the standard of care to perform an oral cancer evaluation. So here I inserted a how to do an oral cancer evaluation through the ADA. This is extremely thorough. I can't say whether or not we should be spending 5 minutes doing an oral cancer evaluation every single time. With that said, all of the doctors are trained on what this is, and this information is available to you. And I'll let everybody decide how they're going to go about doing it. The point is it should be done, and it should be done well. All right, so the frequency of D120, we went over that. This was an interesting point that Dr. Blair put in there. This is not a recommendation, it's just insight in the profession that many people follow. For low-risk hygiene patients with a clean mouth, rather subjective term there, consider extending the routine 6-month prophylaxis interval to 7 to 9 months. This would help to open hygiene time for more productive periodontal hygiene appointments. I'm not advocating for this. As a matter of fact, there's lots of literature saying we should be cleaning even clean mouths every 3 months, 3 to 4 months. I don't see that necessarily happening in the profession anytime soon. With that said, in the world of demand greater than supply, supply being hygienists able to do cleanings, this might be something for us to consider. Just going to leave that out there. Again, this comes from somebody who's a leader in the profession. This is a recommendation coming from somebody who's considered a leader in the profession. I'll just leave it there. All right. So the state dental website, anytime I want to put together something like this, I need to know what the state's expectations are. So here from the scope of practice under hygiene. So if you go to the State Dental Board's website, look under the Dental Practice Act, and then you click on subchapter 4, scope of practice. This tells you what each licensed individual can and can't do and the different supervision requirements of those particular procedures. So this is the heading of that section. Then it goes on by kind of breaking it down. And I just highlighted the relevant things. Of course, there's things like fluoride and can they do cleaning, blah, 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 blah. But this says specifically that a hygienist can, under general supervision, perform all necessary procedures for complete prophylaxis, including root planing. Nothing earth-shattering there. They can also perform complete periodontal and dental restorative charting. So I've had doctors sometimes say, I need to go in there and update the Perio or update the chart in Dentrix or EagleSoft. No, the hygienist can do that. The assistant can do that. Approved by the doctor. Don't quote me on the assistant part. Let's just focus on the hygiene part, because that did change a couple of years ago what the assistants can and can't do. But when it comes to hygienists, they can do all of that data entry, call it screening, so that the doctor can then review. But here's the important part. Perform oral inspections, recording all conditions that should be called to the attention of the dentist. So in the state of Maine, it's very explicit that the hygienist can do all of the data acquisition, not the diagnosis, but the data acquisition which leads to the diagnosis and the subsequent treatment recommendations. So really, to do an efficient exam, I want to shed some light on the importance of this right here. Doctors don't need to be in the room for 10, 15 minutes doing all of this work. The hygienists are cleaning the surface of every tooth. They are far better prepared to see all of the intricacies of a tooth, whether there's a cariologic entity, a decay or periodontal disease, versus a doctor coming in and just quickly going through it. So the job of the doctor is not to do all of that work. The oral inspection and recording the conditions is done by the hygienist and then brought to the attention of the dentist. The dentist can then go through, double check, review, but then have a conversation with the patient. So again, this is 2023. This is from the State of Maine Dental Board website. Every state would be different. So if you're watching this on the NECADE channel, please check with your particular state's rules and statutes. So the medical history review, I was not able to find any sort of standards here. I'm going to spend some more time on this. With that said, I think the hygienist should be reviewing it with the patient. And then when the doctor comes in the room, we're going to go over the workflow in a moment. When the doctor comes in the room, the highlights are brought to the doctor's attention, brought to the doctor's attention where applicable. If the doctor wants to review it himself or herself, that's obviously okay. So here's my proposal for the efficient hygiene workflow in our practices. So I broke it down into 3 different moments of time within the 1 hour that's allotted for a basic cleaning. Again, this is for the non-perio patient. Some of the concepts can translate over there, but again, this is just for the average adult patient. So there's the time spent with the hygienist before the exam is done. So this is before the doctor comes in. Then there's the time with the doctor and the time after the doctor. And I want to go through this, definitely subject to change based upon everybody's insight, but this is a template that I'd like to build out as time goes on. So the hygienist reviews and provides any updates into the medical history. Radiographs and Perio diagnostics, we've gone over that. Again, once per year for radiographs that are needed, once per year for Perio, quote unquote, screening, which is based on our current standards, a full mouth Perio charting of pockets. Screening for conditions based on these diagnostic tools. What does that mean? The hygienist can go through and highlight where there's decay and then bring that to the doctor's attention. And then update the restorative charting. What does that mean? Sometimes patients have work done in other practices. They go and have endo done. The hygienist should be aware of any work that had been done in that interim period and updating the restorative charting. It's not restorative charting, it's updating the charting. I'll make that adjustment in the next overview of this topic. And then start and complete the prophy. All right, so the groundwork is done by that hygienist. All of the information is gathered, whether they put that on a piece of paper, in the chart, whatever modality is comfortable for the hygienist should be used so that that information can be filtered to the doctor in a high-level manner. So then the doctor comes in, always important for the hygienist to introduce the doctor. The hygienist should have some awareness whether or not the doctor has met that patient before. We'll go over this in greater detail once I spend more time on this topic. But in a nutshell, the doctor shouldn't be wondering whether or not they've met that patient. You know, we forget sometimes that we had a conversation with a patient a year ago, but the hygienist should be reviewing the notes enough to say, Mrs. Smith, here's Dr. Johnson. You met him a year ago. Giving the doctor a heads up to not have to say, nice to meet you, and then the patient says, yeah, we met a year ago. That awkward moment should be handled by the introduction by the hygienist. And then the doctor comes in and utilizes a term that we use in the office called greet, meet, and treat. Essentially greeting, hello, Mrs. Johnson, hello, Mrs. Smith. Meet the patient. Talk about something other than just a dental visit, the weather, blah, blah, blah. Meeting provides some sort of humanity to the process. And then lastly, treat, which is, okay, now start doing what you came in to do. This is a very high level, yet highly underutilized technique. Then the doctor should go over the medical history and any general status updates. What has happened? Did they have an MI recently? What high-level information not related to their teeth specifically should be reviewed? Some of it related to the med history, some of it not. Again, the hygienist is disseminating this information to the doctor with the patient overhearing that transfer of information. And then the doctor is then going to take the information from the hygienist and diagnose based upon condition screening. Okay, this wording coming from the CDT code. By quad. This is an important point. One of the most inefficient methods for disseminating information from a hygienist to a doctor is the hygienist rattling off all of the decay in the mouth while the doctor is washing their hands. I personally am not that good enough. Oftentimes when I'm doing a hygiene exam, my head is, in 15 different places because of the difficult root canal I'm doing in the room next door. I found the following to be very helpful. By quad, when you're ready. So when the doctor is ready to do the evaluation. So this is after the med history review is done and the status update is done. The doctor then has the patient open the mouth. I typically like to take a look at their bite, but then the upper right quad is highlighted by the hygienist. So the doctor should say something to the effect of, okay, hygienist, are there any conditions that you saw in your screening in the upper right quadrant? There's no need in going and rattling off all of the decay on tooth 30 when the doctor hasn't even looked at tooth number 2 yet. My opinion, but this works very well when I've employed this with my hygienist. So once that is done, this is really the bulk of the examination. Then the oral cancer screening or the oral cancer evaluation is done. Again, that's a topic for another day, but it absolutely should be done by the doctor. Hygienist, please have a 2x2 out on the patient bib so that the doctor can look underneath the tongue. And then at the end, the doctor should be providing a summary. Sit the patient up or at least look the patient in the eye and say, XYZ, here's what's going on. I found the summary to be very valuable. And then at the end and during this, the eye contact and saying, do you have any further questions? This is an important one. It sounds very easy and obvious. The easy and obvious things are not always done. That eye contact and question inquiry, what do I mean by that? Asking the patient, do you have any questions? Is a very helpful way for patients to feel like they derived value from the visit of the doctor. This is to prevent us from doing what's called the drive-by exam, where the doctor comes in, talks about the kid's soccer team, quickly does a quick evaluation by tapping the masseters, looking inside the mouth, saying ah, and then off they go. That is a very high risk kind of hygiene examination for a variety of reasons. This moment of eye contact is really meant to get us to sit down, look at the patient in the eyes, and make sure that if they have any questions for us, this is their opportunity. It's not uncommon for me to ask somebody, where do you go get your dental care? And they're like, I don't know. I just know my hygienist's name because the doctor never comes in. And when he does, he's in and out. We got to avoid that. That's a low value medical appointment, in my opinion. Done well, this can be done efficiently. So then the doctor leaves. The hygienist should provide an opportunity to clarify any questions. Some patients are scared to ask the doctor, but they can be clarified by the hygienist. Any treatment should be entered. And this is something we're going to work on over time, signing of the treatment plan in the chair during these examinations if any treatment is entered. Topic for another day. Just know this is where we are heading. So how long should this take? The doctor comes in, does all of this, 5 minutes. 5 minutes is not the end of the world for a doctor to spend time away from his or her dental treatment. If done well, it could be less than this. But for most patients that have one or two needs, this can be done in less than 5 minutes. If the patient is going to be that patient with lots of questions, if more time is needed, a 30-minute consult should be scheduled at a later date. Don't let the patient control this. This should be run by the doctor. If the patient is starting to ask questions, the doctor can politely say, Mrs. Smith, I see you have lots of questions and I would love to give you the proper time and attention. And to do that, I invite you back to a 30-minute consultation where we can have an in-depth conversation about all of your questions. So redirected in that way will avoid the patient who loves to talk or just loves to ask lots of questions, or the patient that often gets confused and requires a full work through of all of their problems in their mouth. So we talked a little bit about quote unquote the money's worth. Patients, especially those that pay out of pocket, sometimes have a problem with the drive-by examination. We need to make sure that we go through this process in some depth and detail to make sure that patients don't feel that the treatment was cheapened in any way. So it's all about value building. So look the patient in the eyes and making sure that all their questions and concerns are answered is really the most important thing to do to prevent them from saying, I didn't get my money's worth from that examination with the doctor when they're at the front desk. It happens. This is a good way to prevent that. So again, here's the efficient hygiene workflow. A lot of this is subject to change, but as some of the young doctors join our organization, they sometimes get caught in what should and shouldn't be done. Hopefully this provides more clarity. The doctor does not need to go through and poke every occlusal groove on number 18 and 19 and 20, so on and so forth. The hygienists are very good at that. If the doctor doesn't have trust in the hygienist, by all means, feel free to move forward and do that. Not every hygienist has the clinical skills necessary to do this with confidence. We work on that, but it's the reality of it. The doctor needs to be astute enough to know who are the providers that I can trust to do the screening of information for me. So that's the end of the conversation. I invite everybody to provide insight on what they think. This is something I've been wanting to do for quite some time. Only recently have I had the clarity to put this together in the way that I did. I know this seems super obvious, but I promise you it's not done, including myself. This has been very helpful for me putting this together so that I am more efficient and show up better for the hygienist when we do the exams. I also invite the hygienist to provide some insight on this. And over time, I hope to expound upon this topic into a much longer presentation that we can employ to the dental universe for the betterment of the profession. It's not a secret that when dentists graduate school, there are many things they don't know. This is probably number one on the list. When I graduated dental school, I had no idea about any of this. I had no idea. And if I did, it wasn't highlighted. The problem with dental school is the same emphasis is put on an obscure oral cancer disease as it is to the thing that doctors actually do each and every day. It's up to the doctor once they get out in the real world to actually start learning what's actually important. Again, it's all important, but this is of high level importance because it involves the workplace with every patient that walks in the door. So on that note, everybody have a good day, and I look forward to insight from everyone. Take care.